An introduction to the paradox of modern medicine. Every year, millions of Americans, particularly those over the age of 70, dutifully present themselves for a barrage of medical screenings and checkups. This ritual is rooted in a fundamental, almost sacred belief that more testing equals more safety. We are conditioned to equate vigilance with longevity, and the medical system, fueled by technological advancements in the fee-for-service model, is often eager to comply. For the senior population, this impulse is amplified by the natural anxiety that accompanies aging, a fear of cognitive decline, a fear of catastrophic heart failure, and, perhaps most pervasive, the fear of cancer. Yet, a profound and terrifying paradox lies at the heart of this routine. What the very tests intended to preserve life and secure health are, for older adults, performing the opposite function. What if the constant pursuit of early detection, past a certain age, morphs from a life-saving endeavor into a perilous journey of false alarms, overdiagnosis, and unnecessary, sometimes life-altering interventions? This is the uncomfortable, rarely discussed truth that is buried deep within the scientific literature and often obscured by the sheer momentum of medical practice. The premise is shocking. For a significant portion of the senior demographic, routine, asymptomatic screening for diseases that may never cause harm is demonstrably more likely to introduce complications than provide a meaningful survival benefit. New studies, scrutinizing decades of data from Medicare and large-scale clinical trials, have revealed that up to 37% of medical tests in seniors lead to unnecessary treatments, complications, or lifelong side effects. The term for this phenomenon is overdiagnosis, and it represents a massive, silent public health crisis. Overdiagnosis occurs when a test detects an abnormality that meets the pathological definition of disease, but which would never, in the patient's lifetime, have caused symptoms or death. The consequence is a cascade of iatrogenic, medically induced harm, unnecessary biopsies, surgical complications, adverse drug reactions, anxiety, and reduced quality of life. The most egregious examples on this list of 5 common checkups are not merely pointless. They are actively destructive. 1. The number 1 on our list, exposes patients to a radiation dose equivalent to hundreds of chest x-rays and is now being modeled as a potential contributor to up to 5% of all cancer cases in the U.S., a statistic that shockingly puts it on par with the risk profile of chronic, daily alcohol consumption. This is not an argument against medicine. It is a plea for personalized, evidence-based medicine that respects the context of age, health status, and life expectancy. The science is clear. Once a person is over 70, and especially over 75, the balance of harms versus benefits for many common screenings shifts dramatically. It's time to expose the 5 health checkups that seniors should scrutinize, challenge, and in many cases, outright avoid. The 5 health checkups to question after age 70. Checkup number 5. The bone density scan, DEXA. The illusion of bone fragility. The bone density scan, or DEXA, dual energy X-ray absorptiometry, scan, is marketed as a simple, non-invasive tool to ensure skeletal integrity for younger postmenopausal women. Identifying true, severe osteoporosis, a condition where bones are dangerously porous and highly prone to catastrophic fracture, is a clear benefit. However, when applied universally to the population over 70, the DEXA scan frequently generates a diagnosis that is better categorized as a natural process of aging rather than a disease requiring aggressive intervention: osteopenia. Osteopenia is merely a classification for bone density that is lower than the average of a healthy young adult, but not yet low enough to be considered full-blown osteoporosis. As the human body ages, bones, like every other tissue, undergo remodeling and typically lose some mass. For a 75-year-old, having a T-score that indicates osteopenia is as inevitable and innocuous as developing wrinkles or needing reading glasses. It is the body's new normal state. The costly cascade of overdiagnosis. The problem arises when an age-appropriate DEXA result is treated as a mandate for drug therapy. Physicians, often operating under standardized protocols developed for a younger patient population, feel compelled to treat the number. This leads to the widespread prescription of bisphosphonates, such as alendronate, risedronate, etc., to patients with mild to moderate age-related bone loss who have never experienced a fracture. The literature on this practice is deeply troubling. A comprehensive review of long-term randomized controlled trials targeting populations over 70, such as the one referenced in the original prompt from the Journal of the American Geriatric Society, underscores the marginal clinical benefit. While these medications can slightly reduce the risk of vertebral fractures in those with established osteoporosis, for the majority of seniors with only mild osteopenia, the fracture risk reduction is minuscule, often less than 0.5% over 5 years. In exchange for this negligible benefit, patients are exposed to substantial and often distressing side effects. These drugs are notorious for causing gastrointestinal issues, including severe esophageal irritation and reflux. More terrifyingly, they carry a rare but devastating risk of osteonecrosis of the jaw, ONJ, a condition where the jawbone tissue dies and can lead to disfigurement and chronic infection. Furthermore, long-term use has been linked to atypical femur fractures, a rare but serious break that occurs spontaneously in a previously healthy bone. The irony is stark. A drug meant to prevent a fracture causes a different, often more complex, fracture. The story of Rose and the power of lifestyle. The narrative of Rose, the 76-year-old piano teacher, is a typical illustration of this iatrogenic sequence. She was active and asymptomatic. Her diagnosis of osteopenia, a non-disease in her context, led directly to a prescription. Within months, the severe reflux and jaw discomfort sidelined her, robbing her of her passion and significantly decreasing her quality of life. The treatment for a statistical risk caused a very real, immediate harm. The evidence is overwhelming that for the vast majority of older adults without a history of significant falls or fractures, the most effective and safest intervention is lifestyle-based. Studies have consistently shown that weight-bearing exercises, strength training, using resistance bands or light weights, and rigorous attention to vitamin D and calcium intake can reduce the risk of fractures by over 20%, a magnitude of effect far surpassing the minor benefits of bisphosphonates in an asymptomatic, mildly osteopenic senior. Exercise improves bone density, muscle strength, and, critically, balance, which is the single most important factor in preventing the fall that leads to a hip fracture. The take-home message for seniors: if you're over 70, active, and have never suffered fragility fracture, question the need for a DEXA scan. If the scan reveals only osteopenia, demand a discussion focused on lifestyle modification and balanced training before accepting a high-risk medication. Checkup number 4, brain MRI for mild memory loss. The search for the untreatable lesion. The fear of dementia, Alzheimer's disease in particular, is arguably the most profound anxiety of the aging population. When a senior or their family notes an increase in common age-related forgetfulness, misplacing keys, forgetting a name, the reflex action of many physicians is to order a brain MRI, magnetic resonance imaging. The rationale is to rule out a treatable cause of cognitive decline, such as a tumor, a large stroke, or normal pressure hydrocephalus NPH. While the intention is laudable, the reality of the MRI results in an asymptomatic or mildly forgetful senior over 70 is often highly problematic. These high-resolution scans are exquisitely sensitive and will almost universally reveal age-related changes. These findings include white matter hyperintensities, small spots of damage typically from tiny, silent strokes, and degree of cortical atrophy, brain shrinkage. In the context of an older brain, these are often normal physiological hallmarks of aging, not harbingers of imminent, severe dementia. The psychological and interventional toll. The sheer act of showing a patient an image of their brain with abnormalities has a devastating psychological impact. For a patient like George, the 74-year-old engineer, seeing these white spots, accompanied by a cautious medical explanation, triggered immediate, debilitating anxiety and self-imposed isolation. He received a diagnosis that was technically true. His brain looked like an old brain, but clinically meaningless. His cognitive function was still normal. The scan caused more morbidity, illness, than his actual memory issues. Beyond emotional toll, the ambiguous findings of an MRI are notorious for triggering an invasive diagnostic cascade. The 2021 study cited in Neurology Today, which reviewed thousands of scans for mild cognitive complaints, found that a staggering 86% of scans revealed an abnormality, but only a mere 3% pointed to a clinically treatable condition. This means that 97% of patients received information that either caused panic or led to further unnecessary invasive tests like spinal taps, lumbar punctures, to check cerebrospinal fluid, or in the most aggressive cases, exploratory brain biopsies. These procedures carry real risks of infection, hemorrhage, and post-procedural complications, all in pursuit of clarifying a finding that was likely irrelevant to the patient's actual functioning. The smarter, safer pathway. The gold standard for initial assessment of mild memory complaint is not imaging, but a structured cognitive screening test, such as the MoCA or MMSE. These simple, paper-based quantitative exams are non-invasive, inexpensive, and highly effective at establishing a baseline and determining the severity of the deficit. They quantify whether the forgetfulness is a mild, age-appropriate fluctuation or a pattern indicative of progressive, pathological decline. Imaging should be reserved for those who present with red flag neurological symptoms, sudden onset of severe memory loss, rapid functional decline, severe headaches, new onset seizures, or distinct focal neurological deficits. For the typical senior with mild, slowly progressive forgetfulness, the better and safer prescription is to focus on modifying the lifestyle factors proven to slow cognitive decline, improving sleep quality, ensuring proper hydration and nutrition, managing chronic conditions like hypertension and diabetes, and engaging in brain-stimulating activities. The risks of an unnecessary MRI, panic, and an invasive workup far outweigh the slim chance of finding a rare, treatable condition. Checkup number 3, the cardiac stress test. The pervasive threat of the false positive. The cardiac stress test, whether exercise based on a treadmill or chemical/pharmacological, is a mainstay of cardiology. Its purpose is to induce temporary myocardial stress to reveal blockages in the coronary arteries that might not be apparent at rest. When used for a patient with classic, severe cardiac symptoms, e.g., crushing chest pain on minimal exertion, it is a vital diagnostic tool. However, in the elderly population, particularly those who are simply experiencing nonspecific symptoms like general fatigue, a decline in stamina, or mild, intermittent chest tightness, non-classic angina, the stress test is a diagnostic minefield due to its high false positive rate. In adults over 70, this rate can soar to 40%. The reasons are multifaceted, including non-cardiac causes of fatigue, underlying issues with orthopedic mobility that limit exercise, and age-related changes in the heart's electrical conductivity that can mimic ischemia, lack of blood flow. The unnecessary journey to the cath lab, a false positive stress test, is not a minor inconvenience. It is the first domino in a potentially catastrophic chain of events. A suspicious result immediately mandates a more invasive, costly, and risky follow-up procedure, the cardiac catheterization angiogram. This is an invasive test where a tube is threaded through the arteries, often from the wrist or groin, up to the heart, and contrast dye is injected to visualize the blockages. The data reveals that a significant proportion of these angiograms perform purely on the basis of a nonspecific stress test in an asymptomatic or minimally symptomatic elderly person, find either no blockage or a mild narrowing that may be functionally irrelevant. Yet, the pressure to fix an abnormality once it is seen is enormous. The 2017 study in JAMA Cardiology provided stark evidence. More than half of all stents placed following stress test referrals were in patients who experienced no improvement in survival or quality of life after the procedure. The harms associated with this cascade are immediate and severe: bleeding and vascular injury. Catheterization carries a risk of bleeding at the insertion site, which is exacerbated in older adults who may be on blood thinners. Contrast-induced nephropathy. The iodine-based contrast dye used in the angiogram and subsequent stent placement is highly toxic to the kidneys, leading to acute kidney injury, which can be devastating for an older adult with pre-existing age-related decline in kidney function. Procedure-related complications. Stent placement carries its own risks, including further vessel injury, heart rhythm disturbances, and the necessity of lifelong dual antiplatelet therapy blood thinners, which increases the risk of major hemorrhage. The fate of Raymond and the simpler answers. Raymond, the 75-year-old postman, exemplifies this medical misadventure. His mild fatigue on a hill, a normal sign of aging, was pathologized. The nonspecific stress test led to an angiogram, which identified a mild culprit lesion, leading to an unnecessary stent. The resulting contrast-induced kidney injury and prolonged hospitalization constituted a genuine medical crisis that his body was ill-prepared to handle. His initial fatigue was, as is often the case in older adults, likely related to easily modifiable issues like dehydration, anemia, or suboptimal meal timing. Not a surgical emergency. A responsible approach for the over 70 population without classic, severe cardiac symptoms is to start with non-invasive, lower-risk tests. A resting EKG, electrocardiogram, is a simple and effective measure of heart rhythm and basic function. Even better, a coronary artery calcium CAC score, a low-radiation CT scan, provides a definitive quantitative measure of the actual plaque burden in the arteries. A CAC score 0 is a powerful reassurance, allowing the patient to avoid years of unnecessary worry and invasive testing. A high score can then justify a targeted, evidence-based workup, thus avoiding the pitfall of the high false positive stress test. Checkup number 2, colonoscopy. When screening reaches the point of diminishing returns. The colonoscopy is often lauded as a definitive tool for preventing colorectal cancer, which is true for middle-aged adults. By inserting a long, flexible camera into the colon, polyps, precancerous growths, can be identified and removed before they become malignant. However, as the patient's age advances toward and beyond 75, the long-standing benefits of cancer prevention begin to be eclipsed by the escalating risks of the procedure itself. The underlying rationale for screening changes in the elderly. Colon cancer typically grows very slowly, often taking 10 to 15 years to develop from a small polyp to an advanced cancer. For an 80-year-old in good health, the likelihood of a newly discovered small polyp progressing to a life-threatening cancer during their remaining life expectancy becomes statistically low. The goal of screening shifts from prevention of death from cancer to prevention of morbidity from the screening. The risk-to-benefit ratio reversal. The risks associated with colonoscopy, which are generally low in younger, healthier patients, rise significantly after age 75. Preparation harms. The required preparatory regimen involves harsh, high-volume laxatives that are highly effective diuretics. In an older adult, this can rapidly lead to severe dehydration, electrolyte imbalances, and subsequent acute kidney injury or dangerously low blood pressure, dizziness/falls. Sedation risks. The sedation used to make the procedure tolerable carries a much higher risk of cognitive side effects, prolonged confusion, and respiratory depression in the elderly brain and respiratory system. Procedural complications. The greatest physical risk is bowel perforation, tearing, or significant bleeding, especially if a polyp is removed. The 2019 JAMA Internal Medicine study comparing outcomes in Medicare patients over 70 demonstrated a chilling shift in the benefit-to-risk equation. For every 1,000 colonoscopies performed on patients over 75, only 2 lives were saved, but over 20 people experienced a serious complication, a 10-to-1 risk-to-benefit ratio in favor of the risk. The tragic experience of Dana, the 73-year-old bakery owner, perfectly illustrates this dilemma. She had no symptoms and a clear history, yet the momentum of the screening protocol dictated a repeat procedure. The removal of small, likely indolent polyp led directly to a bowel perforation requiring emergency surgery, a significant loss of independence, and a painful, prolonged recovery. The procedure, intended to prevent a highly uncertain future cancer, inflicted an immediate, certain, and devastating harm. Policy and safer alternatives. Major organizations, including the U.S. Preventive Services Task Force, USPSTF, recommend stopping routine colon cancer screening at age 75 for most individuals and certainly by 85. For those in the 75 to 85 window who are in excellent health and still desire screening, a significantly safer alternative exists: the fecal immunochemical test FIT. The FIT test is non-invasive, requires no bowel preparation or sedation, and is performed at home. It checks for minute amounts of blood in the stool, a key indicator of developing polyps or cancer. While it is a screening test that requires a positive result to be followed up with a colonoscopy, it avoids a vast majority of elderly patients from ever needing to endure the preparation and procedural risks. The FIT test is an example of risk-stratified, conservative screening that respects the patient's age and vulnerability. Checkup number 1, annual full-body CT scans. The apex of overdiagnosis. High dose, zero benefit. We now arrive at the most egregious, potentially most harmful, and tragically, the most rapidly growing trend in unnecessary senior screening. The annual full-body CT scan. Marketed aggressively by private, elite, or executive health clinics as the ultimate early detection tool, the full-body CT promises to find cancer lurking before it has a chance to spread. This is the number one checkup to avoid after 70. The shocking truth is that the practice of generalized full-body CT screening in asymptomatic adults has zero supporting evidence for saving lives. The harms, however, are statistically undeniable and devastating. The dual harms, radiation exposure and incidentalomas. The danger is twofold. 1. Massive radiation exposure. A full-body CT scan delivers an immense dose of ionizing radiation, typically between 10 to 20 millisieverts, MSV. To put this in perspective, this is the equivalent radiation of approximately 500 standard chest X-rays. Radiation is a known linear dose carcinogen. The 2023 modeling study published in JAMA Internal Medicine revealed the horrific consequence of the national rise in CT scan utilization. The accumulated radiation exposure may now be responsible for triggering up to 5% of all cancer cases in the United States. This means the test designed to prevent cancer is, on a population level, directly causing cancer at a rate comparable to a major lifestyle risk factor. 2. The incidentaloma cascade. CT scans are hypersensitive. They detect incidentalomas, small, clinically insignificant abnormalities that are simply part of an aging body, such as tiny benign lung nodules, small cysts on the liver or kidneys, or calcifications on major blood vessels. These are abnormalities that would never progress, metastasize, or cause symptoms. However, the moment an abnormality is flagged on a radiology report, a chain reaction of fear and intervention begins. The experience of Marcus, the 80-year-old martial arts instructor, is a textbook example. His excellent health and confidence were shattered by the detection of a tiny 3 millimeters nodule. This finding led to a referral to oncology, a highly expensive and unnecessary PET scan, and finally, an invasive needle biopsy. The biopsy itself, not the nodule, caused a collapsed lung pneumothorax and a 2-month recovery, leaving him physically and psychologically scarred. The final result, benign, confirmed that the intervention was completely unnecessary, yet the harm was profound and real. The consensus against screening. The entire medical community, including the American College of Radiology, ACR, is unified in its condemnation of full-body CT screening for asymptomatic adults due to its lack of proven benefit and significant potential for harm. The practice is driven by profit margins in private clinics and patient anxiety, not by scientific evidence. The only appropriate use of CT scan is when there is a clear, targetable symptom, unexplained weight loss, coughing up blood, severe abdominal pain, etc., that requires targeted imaging of a specific area. Scanning the entire body without focus is a fundamentally flawed and dangerous approach that subjects a senior patient to unnecessary, substantial radiation exposure, and a near certainty of finding an incidentaloma that will trigger an iatrogenic workup. Seniors should refuse these scans categorically. Conclusion: the new paradigm of responsible aging. The information presented here is not intended to foster distrust in the medical profession, but to catalyze a fundamental shift toward responsible and critical medical engagement, particularly for those over 70. Modern medicine is a miracle of human ingenuity, but its relentless search for disease in an aging body often oversteps the boundaries of common sense and evidence-based practice. The core lesson is this. After age 70, the goal of medicine should often shift from the aggressive search for disease prevention to the preservation of function and quality of life maintenance. When considering any test, especially the 5 listed above, DEXA, brain MRI, cardiac stress test, colonoscopy, and full-body CT scan, every senior or their advocate must ask 3 vital questions. What is the specific, treatable disease this test is looking for in my context? If this test finds an abnormality, what is the next step biopsy, surgery, medication. And what are the quantifiable risks of that next step? What is the evidence that treating this finding will allow me to live longer or better? If the answer to the risk-benefit analysis is unclear, or if the risk of the intervention is higher than the known immediate benefit, then the choice should be clear. Pause, question, and pursue safer, non-invasive alternatives. Real prevention and longevity for the senior population are not found in the sterile environment of the diagnostic lab, but in a sustained commitment to lifestyle medicine, regular, functional movement, strength and balance training, nutrient-dense anti-inflammatory nutrition, quality sleep, and social engagement. By empowering themselves with knowledge and demanding evidence-based, personalized care, seniors can reclaim their health narratives and avoid the dangerous traps of overdiagnosis and unnecessary medical harm. The truth is buried in the science, and the most courageous checkup an older adult can make is a critical one.